Healthcare is nearing the end of a metamorphosis brought on by the Affordable Care Act of 2010 and the Impact Act of 2014. Most of the issues in healthcare come from the ongoing changes, but there are unethical things that still take place. Excess procedures that are not caught. One of the largest fraud cases right here, Medicare included a local cardiologist who just completed 3 procedures instead of 1 procedure and billed for it. And government and the cardiology company didn't agree on whether that was ethical or not. However, most consumer complaints, and especially more vulnerable seniors, comes from the actual system. So let me kind of cover a little bit of this. Healthcare regulation began over a century ago, and it has continued to grow as the government got more involved in healthcare. Basic math skills should project that the government is not very good at figuring out the future. As an example, in 1970, the expectation of Medicare expense was $8 billion. The actual expense, $67 billion. Kind of off. Now, all the calculations that the way that the government does it is based on current tax revenue versus expected revenue. So when the birth rate dropped, and we'll talk a minute how that happened, the number of workers paying in to provide for all that health care dropped. So if you had politics, demographics, cost increasing, longevity, cultural changes, technologies, and economics, you've got all the societal changes showing up in this little thing that we call healthcare. So Medicare started 50 years ago to help pay for hospital costs for the elderly. The first year, total cost, $10 billion. And then the way the government works is they said, well, there's all these other people that need help too. So in 1972, disabled citizens were added. And from that point forth, every 10 to 15 years, the federal government has attempted to reform the system. So the Omnibus Act of 1980 expanded it to home health. The 1982 Tax Equity and the 1983 Social Security Amendment added hospice services and created something called episode-based reimbursements for hospitals. Ever heard of an episode-based reimbursement? So this has gone on now for over 30 years. Essentially, the idea was that hospitals would be able to get paid based upon what a client needed, not on how much time and effort they spent with the client. It's the first time that the government said, let's not pay healthcare professionals for the work they do, let's pay them to keep the person from needing all of those work, because it's called fee-for-service. So I told you we're going through a metamorphosis. Fee-for-service is less than half now. In a couple of years, it will be none. Fee-for-service is a doctor does something, bills Medicare for it, and gets paid. All that's gone away, and it started because of this whole episode-based reimbursement. Every healthcare professional that I know of that's a millionaire was running a hospital in the 80s. Go back and check. Because when they got that episode payment, if someone had a cardiac problem and the episode payment was $18,000, they figured out with all of these new additions, if they would send them to rehab, that didn't come out of the $18,000. If they had home care, that didn't come out of the $18,000. If they had hospice, that didn't come out of the $18,000. So they were whisking people right out of that hospital, keeping the $18,000, and all of those other healthcare providers were billing Medicare directly, to the point that 42% of everything coming out of a hospital, or 42% of the total cost for a patient was what we call post-acute care after you left the hospital. So all of these different people in politics tried different things. In 2003, the Republicans said, let's just throw out prescription drug policy. So that added a whole bunch. 2006, the actual cost of Medicare was $300 billion. Remember, we went from $10 billion to $300 billion. Now the problem is, if you look up there at 2024, it's going to be $1.2 trillion. So in 10 years, it'll be 100 times what it started. Now I happen to live back when all of this was started, and the price of a gallon of gas was 35 cents. So to put 100 times in perspective, this would be similar to today paying $35 per gallon. Does that give you an idea of how healthcare costs have actually worked? So I told you in 2003 they added the famous prescription, and that added another $500 billion. And then figuring out where all the payments from. Now the blue is insurance payments, and the orange is Medicare payments. Now if you notice, none of this necessarily is coming out of just what the consumer pays, but that's all you're going to hear from any politicians. So both private insurance and Medicare Part D still pays the majority. The pharmaceutical industry, once that happened, figured out doctors were not prescribing enough. So they started advertising on TV. The opioid crisis is caused by doctors not wanting to lose patients. Just this week, there was 60 doctors and pharmacists that all got arrested. They had given enough prescription for opioids to take care of every resident in 5 states. Now, the reality is the reason that they did it is because there's so much money in it. So as the reason this is going up isn't because people all of a sudden just need more, it's because they want more. If you talk to anybody over the age of 70, they know all their prescription brands. They'll go, okay, well, I heard about this on TV, doctor. They're coming to the doctors and going, I need this, I want this. And doctors who don't want to lose patients are kind of working through this as, how do I keep them all happy? So disease management and pharmaceuticals has slowly begun to merge and becoming a big part of the problem. So Florida in particular has this enormous growth of seniors. Because Medicaid is managed by state, there's something that all Floridians need to understand. Out of the 50 states, all the taxes taken in from all possible options, divided into what they pay out per citizen, out of the 50 states, Florida is 50th out of 50. So the national average is a state spends $5,777 on a social safety net. Florida spends 64% less than that. Happy taxpayers make sad elderly residents. From 2000 to 2016, Florida didn't allow any skilled nursing homes to be built. Why? Because they didn't want all those people going on Medicaid. But in 2014, they were able to go managed care, so Florida was the first one for Medicaid to be managed care. Managed care equals everything's managed by an insurance company. So insurance companies contract with the state. The state is saving 3% every year by contract, or another way of saying it, those insurance companies that are providing that Medicaid control agree to save 3% every year. In an environment where costs are going up and they're going to pay the healthcare providers less, any idea what that really means for care? You can make that assumption even though the government people will tell you no, is much, much better. So the important part of all of this is that we understand that doctors in particular are going to be accepting more risk, and all healthcare providers are slowly moving towards that Medicare, and all the big insurance companies have become aligned. They're calling this stuff value-based reimbursement. 48 states have grown value-based reimbursement dramatically. The other ones eventually will, and that is what's replacing fee-for-service. So we believe that the average reimbursement will continue to drop from Medicare simply because the environment of more people getting older, having more needs, and the Medicare budget not growing will produce an environment where the physicians' financial motivations have begun to change, and nobody wants the sickest patients. Prevention and wellness will move from suggestion to requirement. It's been 2 years since I found any patient in a hospital over the age of 85 getting approved for operations. So So whether you're on the they should get it or they should not get it, the common term is we've assessed that it's too risky. I had a lady that, broken here. They brought in every specialist, so I guess they've got their money. And conclusion, it's too risky at your age, so off she goes. She's going to spend the next 100 days, and her arm will always be, according to the doctors, at this angle because it's too risky. I could make the case it is too risky, but from a vulnerable senior who, especially their spouse, they want the best for their spouse, they're just going to have to understand this is really the way that it works. About 2% of the people we work with, we end up getting them to move back to the state they came from. Social safety net is still better in Illinois and New York and Connecticut than it is here because they charge taxes. Florida is unlikely to ever change their tax base, so that's a piece of all of that. So another term that they're calling it is population health. So population health means that I get paid the same amount, or in my case, I'm in an Advantage plan, so my doctor gets paid the same every month whether I see him or not. It is supposed to incentivize the doctor to keep me healthy so he wouldn't have to see me. Now, the big change that's coming is telemedicine. My son-in-law works for a not-for-profit in Texas, and part of their new employer insurance is they have to see a doctor online before they can go see a doctor in person. That's part of the way that they're going to save money. Now, a doctor can be much more efficient sitting in an office looking at all the charts, and if you talk to most families today, the doctor's rarely talking to them. They're busy putting everything in the computer. So in this case, there's probably actually more, quote, FaceTime, even though it's virtual, than other ones. A few years ago, I hired a guy to work for us. He was a doctor in India, and he had to go through the boards here. And his father was a doctor in India. His father made $40,000 a year. He made $30,000 a year, and that's big money in India. Now, it only takes one small regulation change for insurance companies to go, you must talk to the Indian doctor or the Chinese doctor online rather than talk to the doctor here. So the days that a doctor is worth $200,000 or $300,000 probably is going to slowly dwindle. There's not enough doctors as it is, so the state keeps allowing them to have more physician's assistants. Not enough nurses, not enough doctors, and technology slowly moving to a point where the primary care physician that knows everything about you that they grew up with is slowly going away. Every trend creates an opposite trend. So there's one called concierge doctors. So last year, before my wife went on Medicare, she had a concierge doctor. Concierge doctor, you pay annual, like you have an attorney on retainer, and same type of thing. They're supposed to keep you healthy. They can talk to you. And other than the fact that there's no insurance payments because they're taking cash, concierge doctors are going to be another piece of this. Now, a lot of people aren't aware of the Impact Act of 2014 because it was called Improving Medicare Post-Acute Care Transformation. Do you remember I told you the episodic payments, it all went out? So the Impact Act of 2014 is creating something called bundled payments. So they're testing this out on 15 or 16 different types of patient health needs, but it's coming, and it's called bundled payments. So they're going to go back to that same system where the hospital gets paid the set amount, except the hospital is going to pay all of those post-acute care costs. So all of a sudden, I go to the hospital, and instead of going to the rehab and the home health and the hospice, just dramatically, you can now go home, straight from the hospital. Or, in the case of Waterman, they built a skilled nursing on ground, so you can now go from this building to this building, but the amount of what's called post-acute care is going to change. And that becomes a big deal because people get used to these systems and have expectations. Our business started in 2012. and 2013, Medicare moved to under observation for getting admitted to the hospital. People are kind of used to that now. When you go to the hospital and you go to your room, that doesn't mean you're admitted. It just means you're in the hospital. So this is going to be the next one that comes. I go to the hospital. I'm expecting to go to the rehab, have home health sent in, and the hospital, whose primary executives are more into money than medical, are going to find ways where that doesn't happen. So this is really what we're talking about. It's called Healthcare 3.0. The entire system is going to this. Doesn't matter who's in Washington, doesn't matter what you hear from all the politicians. We're going to this largely because of the financial pressure of the lifestyle of Americans and the amount of money that's available. So this doesn't matter whether the Medicare for all or the keep your own. This is the system. Integrated health. Patient or person-centered. What it means is each patient decides for themselves what's best. Does that sound good? It's only good if they're informed. Now the problem is patients are not informed. So they're going to come up with all of this data that steers them to where they should be.
I'm sorry. I've been working for the last 5 years in that sector.
Exactly.
And one of the biggest obstacles is that we don't have a centric for medical records. There's no just one place that you can go and get your medical records. So it has big obstacles. It will happen.
Yeah, it will happen. But in the meantime, people are being asked to make decisions without facts. So I got 23andMe, sent off all for my DNA, so I get this thing that says, there's a 2% chance you have this weird disease you've never heard of. So I'm getting informed, but am I really? So imagine a vulnerable senior going to the doctor, and he goes, okay, we have this network that you need to go to. So here is the psychiatrist you go to, here's the neurologist you go to, but absolutely no information that says they're part of an accountable care organization and all the money they save from not providing services to you, they share with the federal government. An informed decision maker is way, way better. E-health capable. Now, medical records, by law, have to be electronic for everybody doing business today. So we've gone through the 5 years of the older doctors retiring or selling their practice, but to Rick's point, they're all electronic. That doesn't mean they talk to each other. So if you have access to your medical records, it may be in 9 different places in file formats that don't match, but even the most informed consumer is struggling to find that. Somebody has to help the poor vulnerable senior who doesn't have a clue any of this stuff's going on.
The biggest problem is, okay, you have all this data. What now? What do you do with it? There's no help that tells you, okay, this affects you in these several ways. There's nothing as of right now.
There are all kinds of technology work going on that will be.
Right.
All right. So, I think everybody knows from a directional standpoint, the problem with big data is the nice doctor that's sitting over in China pulls it up and says, there's only a 22% chance this is really cancer. We'll see you in 6 months. Statistically efficient. In social medicine, that happens. There's a reason Mick Jagger flew all the way to the United States to have his operation from a country that has social medicine. I used to work for a company that was housed in Canada, and I was in Quebec, somewhere I was traveling, and they had this sign on the door that said, we now hiring, we provide health care coverage. And I said, So this seemed kind of odd. And he said, well, in order to find employees, we're having to offer the doctors that don't really exist. I said, what do you mean? Well, they can't legally charge people, but they do. And for those people who don't want to wait to go to the doctor, they can go to. So my guess, we're going to have a two-tier system. All countries have a two-tier system of some kind. Went to Costa Rica 15 years ago, fell off a horse, hurt myself, went to the doctor. There's a doctor, there's a nurse, there's a pharmacist. There's two people there. The whole bill was $40. I said, oh, is this what socialized medicine is? Oh, no. That's at the clinic down the way. This is only private pay. So it's still a good deal, but couldn't have gotten that down the street at the social medicine place. I guess what I'm trying to say is seniors on Advantage plans need to know that the insurance companies are saving money. Seniors on Medicare needs to know that Medicare is busy trying to figure out ways to save money. The patient or the POA is making those decisions. They're able to decide things, but they're not trained, they're not provided tools. Given the right to make decisions without the information somehow seems cruel. So the coming silver tsunami and the demographic squeeze is going to make healthcare advocates a huge need. So you will soon find there will be companies that come up with healthcare advocates, because anytime that there's a problem, that creates an opportunity, and somebody comes up with that is an option.
Where are they today? Because I mean, like, say my wife's getting ready to go through picking her Medicare plan, and if you go to someone selling it, to me, if you don't get someone that has the ethics, so they'll sell you what they make the most money on.
So there's an organization called Shine.
Okay.
It's funded by the state. You'll see they have sessions at all the libraries during October, November, and first week of December. They will go over everything that's available. Now, what makes it difficult is people buy the insurance for next year that they needed last year. And the chances of, oh, I had a knee replaced and it wasn't very good, so next year I'm going to buy the insurance that's good. Well, it doesn't help if you don't need another knee replaced. So the consumer knowledge, patient-centered, what's the likelihood of what I'm going to need next year? So when you turn 65, you can choose any insurance you want because you're on Medicare. The gap policies the following year do not have to take you. So if you have a pre-existing conditions on Medicare and you chose this one, then they have to take you because you chose that one. But the other ones that you did not choose and, oh, you'd like to move over here, they don't have to choose you. So a piece of all of this is if you don't have ethical people to find out from, it really is very difficult just for regular consumers. Hello, Mitch.
Well, that's what I heard, that, once you're on a plan, if you want to go to another plan, you have to take a physical, just like when you're going through private insurance.
Which is kind of odd, since everybody politically makes a big deal out of pre-existing conditions. But the reality is that's what it is all about today, and unlikely to change.